afternoon, everyone. Thanks for coming, especially in this lovely weather. My name is Maria Elena Joyella, and I'm a clinical social worker and the Director of Employee Wellbeing, which is part of Human Resources here at BC. I'm just one little housekeeping thing. At the conclusion of our program today, if you would be so kind as to complete a yellow evaluation on your tables, we really appreciate your feedback and particularly suggestions for future programming. Those of you who joined us last semester in November met Tricia D'Agostino, who is an elder law attorney from the Metro Boston community, and she helped us understand the legal landscape of aging. And then earlier this semester, BC's own Elizabeth Kensinger, who is a professor and chair of the psychology department, spoke with us about why we forget and how to remember better. Today, my colleague Sue Lawler, who's the Assistant Director of Employee Development and Wellbeing, and I are happy to welcome Dr. Jennifer Pilcher to Boston College. We met Dr. Pilcher through attorney Tricia D'Agostino's introduction. Dr. Pilcher is a clinician and the founder of Clear Guidance, Care Management, and Dementia Support, and has a particular expertise in working with families experiencing atypical and young onset dementias. Prior to founding Clear Guidance in 2018, Dr. Pilcher has had a long career working with people with dementia and their families, and that includes working with the Alzheimer's Care Assisted Living programs in Massachusetts and New York. And sorry, I'm scrolling. And then also, Dr. Pilcher has served as president of the New England Association of Aging Life Care and the editor-in-chief of the Journal of Aging Life Care. So as you can see, we are fortunate to have a true expert with us today, and so we warmly welcome you to BC, and thank you for being here.
Good afternoon, everybody. I'm so glad to be here. Thank you to Marie and Suzanne for inviting me. As you heard, I've had a couple of decades now of experience in working with families who are facing a dementia diagnosis. And I'm going to share with you today a lot of what I've learned over the last few decades about how to do this in a way that can be thoughtful and proactive. A lot of people ask me, how did you get into this line of work? This woman here is the reason. This is my maternal grandmother with me. That's me, about 2 years old. This was shortly before her diagnosis with Alzheimer's disease at age 56. This is my grandfather with my grandmother. This was shortly after her diagnosis. He was the headmaster at Milton Academy, many of you know, local place. And this was devastating. My grandmother started to have very strange symptoms. The diagnosis took us 2.5 years. She was diagnosed with everything under the sun you can imagine: depression, midlife crisis, my favorite, menopause. Thanks, yeah. So it was a long road. Once they got the diagnosis, my grandfather needed to retire from Milton Academy as he could not continue to teach. And they moved to their summer place in Westport, Massachusetts, which some of you may know, on the South Coast. They became very isolated from their friends and family who had no idea how to address this disease, how to communicate with both my grandfather, who was grieving, and my grandmother, who had some strange behavior from time to time. My grandfather began to drink more than he should have. He started to neglect his health. He refused to place her in a nursing home, which was really the choice back then. This was in the 80s, right? Not a lot of resources. We didn't know much about caring for people with dementia in their 90s. Forget caring for someone with dementia in their mid-50s. No one knew what to do. So he hired the housekeeper to be his caregiver. She walked off with a bunch of my grandmother's jewelry. Heard this story before? My grandfather carried her from room to room as her mobility suffered because their house couldn't accommodate a wheelchair. One morning, my grandfather got up to take a shower, had a heart attack, and died. We only found this out because my grandmother was found wandering around the neighborhood in her nightgown. Okay, this is not an example of thoughtful and proactive planning. My personal story doesn't end there. This is my aunt, Joni, with me, and my daughter and my godchild. She was diagnosed at age 57. This is my grandmother's daughter. But this story is different. At this point, thankfully I had some training, so we were already a leg up there. But we're in a different industry at this point. There are more choices. We know more. We're more educated. So my Uncle Jack took care of her. She was a part of our family, from our immediate family way out to extended cousins. It was a village taking care of her. There was no isolation. Friends and family all came together. He was the dean of students at Lesley. He was able to stay working full-time because of the support of friends and family, and because he brought in a live-in caregiver early on in the disease process who could grow with them as things were changing. When personal care and care at home got too complicated, he moved her to assisted living memory care, something we didn't have in the 1980s, where she lived another 7 years with fantastic care. He would visit every day after his full-time job was completed, feed her dinner, help her get to bed. His role as a caregiver did not end. She died last year. Hospice was brought in. He was with her for the full week before she died in her apartment, and she died while holding his hand and her family singing to her. My uncle has now gone on with his life. He has grandchildren. He has children that he supports. This is what's called proactive and thoughtful planning. So that's what I want to talk to you about today. How do you make this happen in your own family or for other people that you work with? A lot of people ask me, why should we plan ahead when we can't change the outcome, right? We know the direction that these diseases are going to take. Why can't we just wait till everything's terrible and then make a decision about how we're going to provide care and what we're going to do? These are some of the reasons. The more you plan ahead, the more choice you have. The more you plan ahead with someone who's in the beginning stages of these illnesses, the more they can be part of the discussion, if possible. We'll talk about that in a minute. A lot of places right now, home care, assisted living, nursing facilities are short-staffed. To get the best care possible, you need to plan ahead, you need to get on wait lists, and you need to know who are the good providers that you're going to want going forward. It really helps your health as a caregiver, physically, emotionally, financially, to have all of this planned ahead. It also helps to prevent family disputes, which we do a lot of work around in our field. And of course, it provides you with more peace of mind having a plan that you know ahead of time. Another important point is that the way forward for many caregivers looks a lot like this picture. A vast landscape of different paths to choose, but being unclear which path to choose and why. Many people expect their neurologist to provide this pathway, to guide them through this myriad of options. Unfortunately, that's not a realistic expectation of a neurologist these days. The experience many of my clients have is when they go to the neurologist, and sometimes it takes years, like it did with my grandmother, you finally get that diagnosis that you've been fearing for so long, and the neurologist pats you on the back and says, okay, we'll see you in 6 months or a year, and we'll see how much worse you are. That's terrible. What do you do from there? This is why there are people like me and other people in the aging industry that I'm going to introduce you to that can help you figure out this pathway. But often people are coming to me frustrated that this hasn't been provided by their medical providers. It's just not a realistic expectation at this point. Maybe the most important key to success is to be thoughtful about how the person living with dementia is going to spend their time. I have many care partners that talk to me about, I don't know what to do with this person. They're watching TV all the time. Sometimes they've had to retire as a result of their illness. Other times they're already retired, but they've had to give up the hobbies and the things that bring meaning to their lives. It is important to point out that in order to avoid some of the negative outcomes of dementia, we need to not only keep people busy, but we need them to engage in what we call meaningful activity. So I'm not talking about bingo. I'm talking about meaningful things that are helping other people, things that are contributing to a community. These are the kinds of things we're talking about. And I'm giving you a couple of resources here, and my slides will be available after, so don't feel like you have to furiously write this down. But these are some resources you can go to figure out what does that mean, what does meaningful engagement mean as opposed to just staying busy, and how do I engage the person with dementia in this kind of meaningful activity that is not only going to provide meaning for their life, but also help them to feel connected to their family, to their community, in a very different way than bingo, for example. Another part of meaningful interaction is socialization. And often, as I described to you in the first example of my grandmother, people with dementia tend to become isolated. It is really important to look for opportunities, not just for what purposeful activity can I give this person, but what opportunities to be part of a larger group, to be part of a community. And that can be difficult if that person is struggling. I'm a big proponent of adult day health programs and other situations like that. There are now things called memory cafes where you can meet up with other people with memory loss. And those are offered through the Alzheimer's Association and lots of individual assisted living providers, people like that will offer these memory cafes, which are wonderful, and provide for that social interaction that person may be losing as a result of their diagnosis. One of the things that I often hear about is resistance, right? Many people, with or without dementia, are not a big fan of having someone outside of their family come and assist. And so many people think, well, I'll wait till there's a really big need to do this. I'll wait until I need help with bathing or I need help with toileting. In fact, this is the wrong way to go about that. What you want to do is introduce non-familial support before something so intimate like bathing or dressing or toileting is needed. You need to develop that relationship, and often you need to do it in a slow and gradual way. So bringing someone in for 8 hours a day, not the best approach. Bringing someone in for an hour or 2 hours with a very specific activity that the person with dementia and the caregiver are going to engage in is the best way to do this. At Clear Guidance, we call this crossing the bridge, right? So we're crossing over from I can only have my family, or more typically my spouse, care for me, to I am accepting of having someone outside of my family be part of my life. And then it's much more palatable to graduate into the kind of care that's needed later on. And we find it's much easier to introduce care later on, even if it's a different kind of care, if you've done this earlier on in the disease. And this is hard for care partners. Often care partners themselves are resistant to this. I don't want someone in my home. I don't feel comfortable. What am I going to do with myself while this person is here? That's a lot of what we hear. But it really is important to the long-term well-being of both the care partner and the person with dementia. A lot of the time when we are called, it's because a family is struggling with a particular behavior or symptom that's really challenging. These are two resources, relatively new, that I really believe in and think are good resources for families. The one on the right is written by Brent Forrester. Some of you may know he's a geriatric psychiatrist. He's now with Tufts. He was with McLean for years and years and years. And Thomas Harrison, who's his co-author, is not only an author of many books, but also the son of a mom with dementia. And so they came together to write this book, which I think is incredibly thought-provoking and gives real strategies for dealing with difficult symptoms. The other book is by Josh Friedish, who is a researcher with the Certis Institute down in Florida, and he talks about how you can use color and other parts of the environment to help reduce agitation, anxiety, depression, all of that. Fascinating resources that you might want to use. One of the things that's really hard about dementia is that many people with dementia have a symptom called anasagnosia. Has anyone heard of this symptom before? Anasagnosia means literally the lack of awareness of your illness. This is one of the most challenging issues that care partners face, because you can't have a rational conversation with someone who doesn't have insight into their illness. Let me tell you what this can look like. It can look like a couple of things. It can look like this. I don't have dementia. I don't know what you're talking about. It's not a thing. Or, I have dementia, but it doesn't really affect me on a daily basis. Or, yeah, I've been told that, but no, that's not right. Okay? So different levels of awareness. When you're dealing with a person who has that belief, saying to them, listen, we need to do X, Y, and Z because you have this diagnosis, doesn't work. Or we need to do X, Y, and Z because you have trouble with these things, doesn't work. So communication needs to be different, and it's not necessarily intuitive. So there are a lot of skills that families need to learn in order to communicate with someone that has this kind of symptom. We'll talk a little bit more about that. These are some resources. I'm going to go quickly by this, but these are some resources, both videos as well as articles, that are helpful in learning how to deal with different symptoms of dementia. One of the really important parts of proactive planning for a person with dementia is something we call risk assessment. And as a care partner, it's really important to make sure that you are constantly doing risk assessment. So what does this mean? At Clear Guidance, we like to talk about the line between risky and dangerous, right? So there is no way, particularly in the home environment, but really in any environment, to reduce risk to zero for a person with dementia. There can be issues with safety. There can be issues with mobility and ambulation. There can be issues with safety awareness, so not just actual safety, but your awareness of how to keep yourself safe. And many families have different ideas about how much risk is tolerable. And so it's important to have intentional conversations about risk. How much risk do we as a family accept, right? So when we're having conversations with families about this, we're saying things like, if the caregiver, so let's say we're at home with a one-to-one caregiver, if the caregiver went to the bathroom, which they do have to do occasionally, and mom left the house and was lost for a few hours, are you okay with that? If you are, then okay, we accept that as a risk. If you're not, then we need to talk about what's the next step. Do we need to talk about a different living environment? But it's important to look at the line between, is this something risky or is this something very dangerous? And then to talk about where you are on that line. I have many clients that say to me, I know she can fall. I know she can, or I know she may leave the house. I'm okay with that. I would rather she lived at home and took the risk than move somewhere else. But the important part is the continual conversation and assessment of how much risk you are assuming. In order to be proactive, rather than simply reacting to these issues, we need to be on the lookout for what I call red flags. What does it mean? Where are we having risk? What do I need to be looking for? How do I know how to assess risk? And so these are things we talk to our clients a lot about. What are you paying attention to? So you want to look at, as I said, safety awareness. Does the person know that if they get up, they're likely to fall and they will wait for you to come to them to get up out of a chair? If they don't, that's something we need to think about. We want to look for changes in mood, sleeping pattern, behavior, engagement in relationships, increased agitation or irritation, expressing more anxiety or stress, or more or increased resistance, right? Resistance to help. Things people don't often think about. Other red flags, difficulty with vision or visuospatial issues. Many people with dementia have difficulty with depth perception or with understanding their relationship, their body's relationship to other things in space, not just depth, but also, right? This can come up and family members don't know what to look for. So we often look for things like when approaching a change in flooring, the person either stops or they lift their foot up as if there's a step, but there's not a step, right? So we're looking for indications that the person is not interpreting what they're seeing correctly. Another thing we look for is when there's a placemat set, for example, and there's silverware on the placemat, and the person can't find the silverware as opposed to what's on the placemats. We often see them sort of feeling around for the fork or trying to pick things off of the placemat. Those are all indications that we've got some visuospatial issues. Obviously, negotiating stairs or flooring changes, change in gait or balance, loss of interest in prior activities. Depression is a huge issue for people with dementia. We want to make sure that the environment is supporting that. And it could be that without enough socialization or membership in a community, that we need to change the environment the person is in. And then, of course, most of all, what is the experience like for the care partner? What is the stress level of the person that is caring? We need to see that as an indication that we might need to have a change. Two other areas of risk I want to mention very quickly. If you're caring for a person over the age of 65, there are two major reasons that older adults lose their independence. One of which is falling. The CDC is predicting that by 2030, there will be 7 fall deaths every hour in the United States. That's crazy. Falls are serious, not just because they can lead to injury, but because they change your ability to ambulate, which then leads to infection, which then can lead to an increase in death. So making sure that we are on top of this and aware of it and then react when we have a near fall as opposed to a fall, really important for keeping our older adults independent. The second reason might surprise you, which is medication errors. The data is really scary when you look into this really carefully. And we think about medication errors being the person taking the medication, taking the wrong dose, or not taking it. But in fact, medication errors can happen anywhere in the system. From the moment the doctor writes the prescription, calls it into a pharmacy, the pharmacist fills it, you get it, it comes to your home, and then you take the medication. Anywhere in there, mistakes can happen. And the number of mistakes that are made by medical professionals and pharmacists is alarming. So it's really important when working with an older adult that you write down in the doctor's office what was prescribed, what dose, and how you're supposed to take it. And then you make sure that's the same thing that arrives in the home. Another key to success that care partners often don't know about is health insurance. It's likely that at some point a person with dementia is going to need a rehab facility. There are these products out there called Medicare Advantage plans. I was shocked to find out my own parents are in a Medicare Advantage plan. And the reason these are attractive is because it's less expensive. The premiums are less expensive because somewhere like Tufts or Blue Cross, they are managing your Medicare. But in reality, if you need rehab, whoever that entity is that's managing your Medicare also limits your choices for where you can go for rehab. So when a person has been diagnosed with dementia, this is a really important point to look at what they have for Medicare. Ideally, what you want is traditional Medicare with a supplement, not an Advantage plan. There's a free resource at basically in every town through your Council on Aging called a SHINE counselor, SHINE. You can go to them, you can show your insurance, and you can have a discussion for free about what's the best insurance for you to have. Also, there are private people, I don't know if you can see, it's way on the bottom, that are Medicare advisors. I've given you one here that I work with a lot, who can also help you look at it and then help you figure out when to change it. There's open enrollment, but also a diagnosis is an opportunity to change your health insurance. So it's something to really think about so that you're not getting stuck and you're not calling my office on Friday afternoon at 4 o'clock saying, I can't get my mom into the rehab I want to get her into because of her health insurance. So we can't fix that at 4 o'clock on a Friday afternoon. So something to really pay attention to. Most people have had some advice about legal and financial planning. Even the neurologist, as limited as they are, usually gives some advice about financial and legal. Most people know you need to have up-to-date estate planning documents such as a will, power of attorney, and a healthcare proxy. This is good advice, but to be truly proactive, you need to understand and appreciate why this is important. The first reason it's important because at some point, the care partner will have to make decisions on behalf of the person with dementia. This will happen at some point. Competency is a big issue in dementia. At what point does a person have the ability to make their own decisions, and at what point do they not have the ability to make their decisions? There's a lot of gray area here, and it can be a real sticking point for a lot of families. So basically, when we're talking about how do we know if someone is able to make their own decisions, has sort of three parts to it. A person who can make their own decisions knows what questions to ask about their diagnosis and about what the possible outcomes are. They understand and accept the possible consequences of treatment or not treatment, and they can incorporate new information into the decision. That's the highest level of sort of decision making about your health. So this is what we're thinking about when we're trying to decide, does someone have the ability to make their own decisions? These are the documents that we often are suggesting and the steps we often suggest people do. One of the reasons why this is so important is because if you don't assign decision makers for yourself ahead of time, then when you do lose the ability to make decisions, a court has to take over and assign a guardian or a conservator. Nobody wants that. Nobody wants a stranger making their decisions. However, the way to talk about this is how much control you want to have over decisions in the future. And so it is really scary for someone with dementia to have this conversation because it implies the idea that at some point they won't be able to make their own decisions. But I've had more success in talking to care partners and people with dementia in talking about this is the way for you to have control over what happens in the future. So really important when you look at it like this. There's also another document that people are not all that aware of that's just really important. So one piece of information about a healthcare proxy I want to give you. People often think, well, I have a healthcare proxy. I've already said who I want to make my decisions. And often adult children or care partners think if they just present the healthcare proxy to any medical provider, they're going to give them information. It's not true. There's another step that needs to happen, which is that a medical doctor needs to invoke or activate the healthcare proxy in order for you to use the power of the healthcare proxy. Otherwise, it's just a document over here until you can't make your own decisions. And so this can cause a lot of issues, you can imagine, right? I need to know what the neurologist is saying to my spouse or my parent, but I can't because the healthcare proxy isn't invoked and my parent can make the choice to have me not have the information. One of the ways around that is something we call a HIPAA release document. You've probably signed one of these at your doctor's office at some point. And what this says is, no matter what my decision making is, the person I name in my HIPAA release form can have information about my health starting the moment I sign it. And this is something that not a lot of people know about, and it's a really important third arm to the documents that we're signing. It can avoid a lot of heartache and difficulty later on. It's also really important for the person who is the decision maker to understand what the needs and wants are of the person with dementia. These are really difficult conversations to have, but really important to have. There are two websites and approaches to this that I really like. One of them is called Honoring Choices. It's in Massachusetts. They have a whole bunch of literature about how do you have the conversation, what do you need to do. And there's this other document called the 5 Wishes, which has you can get it on their website, which gives the questions. How do we talk about this? What do we ask? What are the questions we ask? And what's the kind of detail? It's not a legal document. It's guidance for the person who's going to be making the decisions in the future. So those are two important resources for you to use. Along with the legal documents, it's also important to plan ahead for the cost of care in the future. Many people are surprised to find out that typical health insurance does not cover care. If you're over 60, there are some programs you might be eligible for that can offer with assistance for paying for home care or assisted living. If you're younger than 60, you may be able to apply for disability through Medicare. So these are some of the resources that are available for people to get assistance with care. Most of the time, unless you meet the requirements of Mass Health, which I'm sorry to say is about $2,200 a month in income and less than $2,000 in assets, you're going to be private paying for your care. So let's talk about what that looks like. And this is important information. And again, these are in my slides, so you'll have access to all this information. But these are the kinds of care that are available at home, and this is the kind of cost that we're looking at. And so knowing this ahead of time, planning for this, and deciding how are we going to pay for this, and is it possible to get any supplement to help us with this is really important. Again, my favorite, day programs. Here's the cost. Mostly it's private pay. Veterans can often get help with that, so that's an important other piece of that. To plan ahead, you need to get familiar with the types of residential options that are out there. I've given you a slide that looks like stairs, and the reason it looks like stairs is because on the bottom is the least amount of assistance available, and the top is the most amount of assistance available. So how do you know where a person with dementia fits? How do I know which level is appropriate? Often there are people at the Council on Aging or the Senior Center that can help talk through these issues with you. If you're in a hospital or a rehab setting, there's a discharge planner who can talk over these issues with you. If you're looking at placement, sometimes the people that are going to receive you on placement can talk to you about what's most appropriate, what they think is most appropriate. And then I don't know if Boston College has an EAP program, an employee assistance program, but often there are benefits through that where there are experts that can help you with that determination as well. And then there are people like me in the world that help people as well with determining that. Again, just a brief mention of what assisted living looks like these days and the cost. I've also, on the bottom, given you a couple of resources about how to choose a residential care community. What do you need to think about when you're doing that? And also, what do you need to ask when you're looking at an assisted living program so that you know you're getting into a high quality community, but also one that's going to fit for the person you're caring for. This gives you an idea of the cost of long-term care in a nursing home. Short-term care, rehab, usually covered by Medicare or an HMO if that's what you have. But once you need to stay there a long time, the cost is very high at this point. So important to know that. And important to know that if you have folks that have some resources, they will have to spend down those resources in order to have Mass Health cover the care in a long-term care setting. So if you know someone that's in that middle situation, really important to go see an estate planning and elder law attorney to do the planning for that and figure out how you're going to get Mass Health. This is the only level of care that can be totally covered by Mass Health, but you have to spend down all your assets first in order to become eligible. Down here I've given you two resources. One is the Nursing Home Compare website, where you can go in and see how that nursing home scored on their survey. They have an annual survey, and you can go see what their score is and where they scored on quality, staffing, and health inspections. So that's an important resource if you're looking for that. And then again, what you want to ask when you're looking for that level of care. The one thing you do not want to do when you are looking for a community is Google. Please don't Google. The truth of the matter is that the people that leave Google reviews are the ones who are really happy or really unhappy. And so you're not getting that middle perspective. Also, be careful about asking your friends and family what their experience was like. Rather, I've given you a couple of different websites where you can go and search for what's in your area. And then what I would do is ask that community to give you a couple of families to talk to that have people that are living there right now. And the most important thing is ask them to give you a family who had difficulty, but they were able to resolve it. So not just people who have been elated since the moment they arrived, but who experienced some challenge and the facility was able to help them overcome that challenge. That speaks more to the quality and the responsiveness of the staffing than anything else. Be careful, and I know I'll get pinged on this one day. Somebody will get mad at me for saying this, but this is true. There are places like A Place for Mom. People know these places. Be careful. These places are paid by getting, kickbacks from facilities. So certain facilities give them a fee if they refer to them. And not all of them do. So who do you think those folks are more likely to refer you to? The ones that are going to give them $2,000 for your referral, or the one that isn't? Be careful. It's good for information, it's good for location, it's good for amenities, but be careful. Maybe one of the most common questions I get is, how do you decide? How do you decide if you're going to care for someone at home or you're going to consider a community? There's no right answer here. This is personal choice. It really is. And it's really depending on the circumstance. You need to think about timing. You need to consider what we talked about before, about social opportunities. How much opportunity is there in the home environment for socialization? How much is there not? Often this comes down to a financial decision. 24-hour care at home is really expensive. If that's what you need, you might be able to save a lot of money by having that care in a community instead. And it doesn't have to be all or nothing. You're not deciding I'm caring for this person for the rest of their lives at home, or I'm caring for them in a residential community. You can do it at home until it doesn't work and then make a decision to move. But you need to be ready for that. You need to have picked out the places that you feel comfortable with and get on the wait list. You can always say no when your name comes up. But if you're not on the wait list and you have a need, then you're going to be stuck waiting longer than is appropriate. I'm just going to finish here by talking a little bit about care partner stress. If you were running a business as a care partner, you would not want your organizational chart to look like this. You need a team of people. You need a village. You need people that can help you with legal and financial and care. You need to find, often your neurologist has a social worker that works in their office that can be supportive of you. Take advantage of those resources so you're not alone. The data on caregiving is not good. Think back to that story I told you about my grandfather. It happens a lot more than you might even realize, that the care partner passes away before the person with the illness because of the stress of caregiving. Just in case you didn't get it from the prior slide, I'm giving you a few more data points on really what happens to people's health as they caregive. And so making sure you have enough support and that person has time to themselves is so important. So at Clear Guidance, we believe that if you're brave enough to live with dementia or to be a partner to someone who's living with dementia, you're a superhero. But no superhero can do it alone. You need a group of sidekicks. And so I hope today I've given you some ideas about what those resources are and who those sidekicks might be, so you can continue being a superhero as you go forward. So I'm happy to take any questions you might have. Yes?
I'm concerned about the statistics about falling. Is there a way, how can you prevent people from falling?
Great question. So the first thing I would suggest is that you're entitled to physical therapy as part of what's covered for your medical insurance. So calling your primary care provider and asking them to give a referral to physical therapy. Physical therapists will come out and do an assessment. And we'll watch you walk, we'll watch you get up, do all kinds of things for that person and make suggestions to you about what you need to do to avoid falling. There's also a lot of resources, I'm pretty sure I put them in there, but if I didn't, I will email them to Suzanne, about what do you need to think about in your home, right? So often we're looking at things like throw rugs. They're beautiful, but they can cause a lot of falling. Making sure that you have grab bars and things like that to hold on to, particularly in the bathroom. That's where most falls occur, in the bedroom or in the bathroom, especially when you're getting up at night because you're already sort of a little off kilter. I know this about myself. And so, making sure that you've got appropriate footwear when you're going to the bathroom in the middle of the night, making sure you give yourself a second. I have very low blood pressure. If I stand up too fast, I'm gonna sit right back down. And so knowing that about myself helps me to prevent falling in my own life. I also have a handy dandy thing called fall detection on my Apple Watch. We use a lot of technology now in the work we do. It can detect near fall, not just actual fall. And so that's really important in terms of looking at your risk of falling and how to mitigate that. I hope that's helpful.
So what type of professional?
Oh, sorry.
So what type of professional would help you with figuring out all those things you need to do? Is that an occupational therapist? And if so, how do you get to that service?
Meaning to avoid falling?
Correct. Yeah.
Yes. So the PT will come out and evaluate the person's gait, balance, all of that. And then the OT is the one that says you should get a grab bar here, you should get rid of this rug, you should do that. And they often come together.
Okay. And
But you might have to
through
ask.
your primary care?
Primary care. Yep. Over here, then over there.
Sorry. Hi, thank you. I'm in a situation sort of like your family where I'm worried about the caregiver and his stress level.
Yeah.
And so in terms of beyond like books and resources treating, like what types of communities are there out there to maybe refer my father-in-law, for example, to partner with other folks who might be going through the same, is there a cafe, while she's in a memory care cafe, do they have like a group for caregivers, partners? I think, books are great, but he needs like a strategy. Like, what are some devices you would use when your partner is asking, oh, I have to go to work today? It's like, no, you don't. Like, these
Right.
common
Communication skills.
Yeah. So to not isolate him and realize that he's not alone either.
Right.
So I'm worried about that, or if there's any opportunity I could refer him to.
Yeah.
that.
So my answer is two parts. We used to have much better supports for this before the pandemic. The pandemic did a number on these things. The Alzheimer's Association does have support groups, and they're separate. Like, you can just do a caregiver group, or you can just do a patient group, or then there are some that are together. So that's where it starts, is going to the Alzheimer's Association website, and it lists the different support groups that are available. And there are ones that are specifically for people who are in early stage, specifically for people who have frontotemporal lobe dementia as opposed to Alzheimer's. So do a little research there, and I'm happy to give you, if it is an atypical dementia, I can give you some other resources, but that's where to start. There are wait lists for these things now, but it's worth getting on it because you don't know, and they're both virtual and in person. So that's worth doing. There are also workshops through the Alzheimer's Association about communication and how to do it better, where he can bring up his own questions and they can sort of role play. One of the things I think is really neat that we've just started, I haven't worked this into any presentation yet because it's new, but we're starting to get some training on improv with dementia, which I think is fascinating and feels a lot better in terms of thinking about communication. So the number one thing is someone with dementia has a different reality than we do. Rather than trying to convince them that their reality is wrong, we need to enter into that reality. And if you think about that like improv, then you sort of, oh, okay, so if I'm doing improv and they're in 1973, okay, let's go to 1973. What was happening? Let's talk about it, right? And so that feels different than some of the other training that's been going on, where you have to think about a specific answer to this question, as opposed to I'm just rolling with it and I'm just going to go where that person goes, right? Yeah. And then there are people like me that do coaching on communication. And I'm happy to, should have put this up before. I was the president of the New England Association of Aging Life Care. And so if you go to aginglifecare.org and you put in your zip code, you get a listing of people like me that do this kind of coaching with families. Yeah. Anybody else? No? Oh, hang on.
This could be very specific to the person that I'm talking about, but something he started doing is he now is more irritable, but also what he does before, I think not just going to bed, but in general, he comes up to the sink, takes a squeegee, and just starts cleaning all of the water drops, even when he knows that the next person's going to wash the hands right away. Mm-hmm. So I asked why he does that, and he said to make sure it looks nice and neat. Mm-hmm. And I was wondering how to react to someone doing that. Do you just kind of not talk about it? Is there...
Let him do it. It's purposeful. He feels like he's doing something important. He's making it look good. He's cleaning it up. And hey, it's an activity that he's doing to the benefit of his household.
That is a good way to...
What I would say is, thank you. That's great. And even if it's, 25 times a day, that's okay.
Okay.
This is like improv, right?
This is helpful, yes, thank you.
Yep. Back here, Suzanne.
Thanks. I was just going to mention in a tough spot where the person is in a very stubborn place, has already fallen multiple times, broken finger, split open the head, recovered with us, insists on living in a big house alone, won't wear the life alert when goes out. Well, I mean, we're all working all day long. Nobody's there. Doesn't it's really tough. Like, is there a point where they'll finally, accept? I mean, it's hard. I just don't. I feel like every day is like, I don't know what's gonna happen. Like,
Yeah.
I'm gonna fall again.
So I have a couple answers to that. One is sometimes things get easier as the disease progresses because objecting as vehemently gets more difficult. But there are certain interventions that you can do. Some of them are legal, right? There is the opportunity to get sort of elder protective services involved, and if they felt that there was something really dangerous, then they would take action. They don't always, so it has to be sort of an extreme situation. The other thing I would suggest is often I will bring the primary care into the conversation, where I will let the primary care know. HIPAA can work in one direction, so the primary care can't tell me anything, but I can tell the primary care everything I know and bring it to their attention that this is going on. There are multiple falls, there are injuries, all of that kind of thing. So there are certain interventions that you can do along the way. And then there's also a strategy we call watchful waiting, which is having a plan in place about what you will do the next time that person ends up in the hospital or has an injury to change the situation. And again, then we have to deal with competency, right? Because you have the assumption of right to choose unless a doctor says you don't have the right to choose. So adults, even adults with dementia who are competent, can make bad decisions. And there's this gray area of, are we making bad decisions that are risky and are allowed to be made, or are these dangerous decisions that are endangering yourself or somebody else? And so it's a murky area, but bringing in the primary care, considering bringing in elder protective services, and then creating a plan for watchful waiting so that you can act when something does happen. And then you're at the negotiation table where you're saying, if you want to go home, here's what we need to put in place so that you can be safe at home. And that's your moment, right? So that's a lot of what we work on, is different strategies about how do we intervene, and if those interventions don't work, what's our fallback? Anything else?
Anybody else? No. Thank you, Jennifer.
Of course. Thank you.